Hey everyone, thanks for taking time to watch this training. Today we're going to talk through how to respond when a client is in crisis and may require involuntary hospitalization, what's commonly called a 302 in Pennsylvania. And a 302 just refers to a specific part of the Pennsylvania Mental Health Procedures Act, which allows for the involuntary emergency evaluation and treatment of somebody experiencing a mental health crisis. It can be initiated when a person is deemed to be in danger to themselves, to others, or unable to care for themselves and refuses or is unable to agree to voluntary treatment. The initial 302 commitment authorizes up to 120 hours or 5 days of inpatient treatment. Now, it's important to understand that not every state calls it a 302. Some may use terms like civil commitment or have different codes like 5150 or processes. But since JADE is in Pennsylvania, our training focuses on the local procedures and legal responsibilities under Pennsylvania law. So when do we consider a 302? That's usually the biggest question that I am asked when I'm training a new employee or intern. And it's really only when a client's behavior presents imminent risk. So that just means that without intervention, there is a real chance of harm to self or others. And this could include suicidal ideation with a plan, intent, and means, homicidal threats that are credible and specific, or severe neglect of basic needs that puts a person at risk of death or serious harm. So if somebody is open to help, we always want to start with voluntary options, also known as a 201 admission. And that means that they agree to inpatient care. But if they refuse and still meet criteria, that's when we move to a 302. And this applies across the board, whether we're working with somebody in mental health treatment, substance use treatment, or both. That said, there are specific legal restrictions that we need to follow, especially for clients under 42 CFR Part 2, and that's the federal regulation for substance use treatment. So we're going to break that down in a minute. But first, let's get started with just talking about how to start a 302 petition. And we'll go more into detail later, but here's a basic overview of how the 302 process typically begins. First, you're going to contact your supervisor or the clinical director immediately. They'll help guide the process and confirm whether a 302 criteria are being met. Second, we'll call the appropriate county delegate or crisis line. In Allegheny County, that means calling Resolve Crisis Services at 1-888-796-8226. And each county handles this differently, so make sure that you have access to the county contact list, and you can find this on our shared drive or posted in the office, or maybe in your email because I might have emailed it to you already. The third step is if the client is off-site or needs immediate transport, we want to call 911. And you're just going to say something to them like, hey, I'm with a client who meets 302 criteria. We contacted delegate and they need to be transported for emergency evaluation. You do not want to leave the client alone if they're on site until a transfer of care has occurred, whether that's EMS, police, or mobile crisis. And of course, we're going to document everything and complete some incident reports for DDAP and the client's insurance or county funder like CCBH. And so this might feel like a lot in the moment, but that's why you're never expected to do it alone. Ask questions, slow it down, follow the steps with support. And the bottom line here is that our goal isn't to decide if somebody needs inpatient care forever. It's to assess immediate risk and make sure that we're taking the right steps to keep people safe right now, legally, ethically, and compassionately. All right. So once we understand what a 302 is, the next step is knowing when we might need to consider it. And this starts with recognizing risk in real time. So let's break it down into two main areas. There's suicidality and homicidality. And the key is learning to recognize the difference between general distress and actual crisis that puts someone or someone else in danger. When we assess for suicide risk, we always want to look at how specific the ideation and how far along someone is in the planning process. So passive suicidal thoughts might sound like, I wish I just wouldn't wake up, or it wouldn't matter if I was here or not. And these can definitely still carry risk, but they don't always require immediate hospitalization. They do, however, warrant further conversation and assessment. Active suicidal ideation is different, and that's when a person says things like, I want to kill myself, or I've thought about how to do it. And when somebody has a plan, intent, and access to the means, that shifts the risk level, and it means we need to act really quickly. So what do we assess? First, do they have a plan? Do they have the means? That may be pills, weapons, or whatever specific method is part of their plan. Do they intend to act? Do they have a history of attempts? And are they open to voluntary treatment, or are they refusing help? So tools like the Columbia Suicide Severity Rating Scale, or the CSSRS, and the PHQ-9 can help you organize this assessment. But use your own clinical judgment and conversation skills. These are just as important. Use clear, non-judgmental language. You're not putting ideas in their head. You're just creating space for honesty and support. So, some specific examples that might warrant a 302 would include a client saying something like, I've already picked the bridge. I'm going to go tonight after work. I've got nothing left to live for. Or if they're saying something like, I'm saving my anxiety meds so I can take all of them at once when my kids leave this weekend. Another example might be a client being visibly disoriented and saying that they haven't eaten or taken prescribed insulin in days, refusing all support and insisting that they'd be better off dead. Or a client reporting attempting to hang themselves a week ago and is still experiencing strong urges to try again, but refuses to go to the hospital. So, just as a reminder, these behaviors do not have to be happening in the exact moment of the session. If the risk behavior occurred within the past 30 days and the client remains unsafe, it can still qualify under 302 criteria. And assessing for homicidality follows a similar structure, but with a different focus. So, not every angry client is in crisis. Somebody saying, I hate my boss or I'm so pissed at my ex doesn't necessarily mean they're going to act on it. But if a client says, I've thought about hurting somebody or I want to kill a specific person and I know how to do it, that's active homicidal ideation and it needs a different kind of response. So, here's what we assess. Is there a specific target? Do they have the plan and the means? Have they committed any acts in furtherance of the threat? So, like driving by somebody's house, purchasing a weapon? Do they have a history of violence? And do they have access to weapons or recent stressors or triggers? So, if there is a clear plan and intent and they're refusing voluntary hospitalization, that's a situation where a 302 may be necessary and where legal considerations around duty to warn and substance use disorder treatment versus mental health treatment may come into play. And we'll go into that next. So, now that you've identified that the client is at risk, what happens next? This is where we triage. So we'll figure out whether the situation requires immediate external intervention or if it can be managed safely in the outpatient setting with support and planning. So if risk is present but no imminent danger, so let's say that the client is struggling, they're overwhelmed, maybe expressing passive suicidal thoughts or general hopelessness, but there's no clear plan, intent, or means, they're open to support. In this case, we would create a collaborative safety plan with the client. This includes warning signs, coping strategies, or people or places to contact in crisis. So this is where a crisis plan could come into play, or there's even also a separate document called a safety plan that you can use to help guide this conversation. You want to increase contact frequency, such as adding a second session that week or doing a brief check-in call midweek, and offer referrals to psychiatry, peer support, crisis stabilization services that can add layers of safety and support for the client. And this situation still requires documentation and clinical attention, but it doesn't rise to the level of involuntary commitment. Now, if imminent risk or danger is present, so we're talking suicidal or homicidal risk, there's a clear plan, means, and intent, or the client is unable to care for themselves in a way that puts their life in danger, this becomes an emergency. So here's what we do. One, don't leave the client alone. Whether you're in person, on a call, or even in a video session, stay with them virtually or physically until a transfer of care occurs. Ask about voluntary hospitalization or a 201. Say something like, hey, I'm really concerned about your safety right now. Would you be willing to go to the hospital to get help today? If they agree, we're going to coordinate a 201 admission. If they refuse, we're going to begin the 302 process. So, depending on where the client is located, the steps might change. So, if the client lives in Allegheny County, you can call Resolve Crisis Services. They operate 24/7 and will walk you through the petition process, including connecting you with a delegate who will review the case and determine whether or not they can authorize a 302 legally. For other counties, you're going to contact the assigned county delegate or crisis line, and a contact list should be posted in your office and saved on the shared drive. And also, I've emailed it to you. But if the client is off site and cannot be safely transported by family or staff, we're going to call 911 and clearly state, hey, I'm working with a client who meets 302 criteria. We've contacted the delegate and I need the client transported for emergency evaluation. You're going to maintain supervision of the client until emergency services, police, or a mobile crisis unit arrives. Never leave them unattended. And you're going to notify your supervisor or clinical director immediately, and they can support you through the petition, help debrief after, and ensure next steps like documentation and reporting are completed. And this can feel really intense, especially the first time. That's why we never want you to do this alone. There's always going to be somebody to help walk you through it. And we can get the med staff on board. We can get the CEO involved. We have a ton of people at your disposal to be able to support you through this decision-making process. You are not going to be alone in doing this. So let's talk about the legal side of risk, especially when it comes to what we're allowed to say and to whom when somebody makes a threat. So 302 laws vary by county. So even though 302 is a state law under Pennsylvania's Mental Health Procedures Act, the process for initiating one varies by county. Some counties use paper petitions, others have online portals, and some require going through a crisis service or delegate first. So it's important to check the current process for your client's county, especially with telehealth, and consult your posted guide or supervisor. Don't just guess at this. And if a client makes a credible threat to harm somebody else, say, I'm going to kill my brother tonight and I have a gun, you're likely thinking, I need to do something to protect that person, to protect his brother. And yes, clinically, you absolutely do need to respond. But how you respond depends on whether the client is receiving mental health treatment or substance use treatment or both. So for clients in mental health treatment, not substance use disorder treatment, if a client is receiving only mental health services, you may be legally and ethically required to initiate a 302 petition based on homicidal intent to ensure that the client is evaluated and possibly hospitalized. And the second step of this is to make a reasonable attempt to warn the identified target. This is what's known as the Tarasoff ruling, and it's recognized under HIPAA. That disclosure, even if it breaks confidentiality, is legally permitted when it's to protect somebody from imminent harm. Now, again, this is for mental health treatment, not substance use disorder treatment. For clients in substance use disorder treatment, so the clients that JADE serves, if the client is receiving services under state licensed drug and alcohol program, then 42 CFR Part 2 applies, and the rules are even stricter. So this means you can still initiate a 302 for homicidal ideation. The petitioning process works the same as if the client were suicidal, it's just a different risk, but you cannot directly contact the identified target or anyone else to warn them unless the client had signed proper written consent already, which I doubt would happen here. A court order is obtained, or it qualifies as a medical emergency that affects somebody else's life and disclosure is necessary to prevent death or serious harm. So even if the threat is real and terrifying, we're still bound by the confidentiality rules under federal law. And that's why it's essential to document thoroughly, begin the 302 process immediately if risk is present, and involve the clinical director right away. And they'll help determine if further legal steps are needed. So JADE is a licensed substance use disorder provider, and in the future, we may expand into separate dual mental health programming. And you might not always work in a setting like this, too. So it's important to know that in mental health settings, you have a duty to warn the potential victim. In substance use disorder treatment settings, in a state licensed facility like JADE is, where 42 CFR Part 2 applies, you do not have a duty to warn unless very specific criteria are met. So remember, the clinical response, the 302 petition, is the same. The other legal part of this that we want to consider is Act 77. So clients that are committed to involuntary holds lose their firearm rights. So this has to be reported to state police. Clients can appeal it, but it happens immediately. And this isn't something that you're going to be reporting. This would be something that the inpatient facility would report directly to the police if the 302 is warranted. But that's something just to keep in mind, especially when we're working with maybe some rural clients where guns are just part of their life or perhaps their livelihood. We want to be really cautious about this. Moving on to documentation. So once the immediate risk is managed, the next most important step is documentation. And we're not just talking about covering yourself. This is clinical continuity, compliance, and making sure that the client's care story is clear for anybody who touches the chart next. So within 24 hours, make sure that you document the following in the client's chart. Going to be your risk assessment. So you're going to include direct quotes if possible, your clinical observations, and your level of risk determination. So this might be happening in a DAP note if the disclosure was made during a session that you're billing for, or if it was a separate phone call, it might be in a contact note or a memo to chart. You're going to want to document the actions that you took, such as offering a 201, initiating a 302, or contacting a delegate, and any safety planning or de-escalation intervention, like maybe calling an emergency contact. You're going to also want to document the client's response. Did they agree to go voluntarily or were they resistant? You're going to want to include documentation of any consultations with supervisors, medical or crisis staff, and any referrals or follow-up plans, including psychiatric or peer support. And then if the situation involved emergency services, a 302, or significant safety risk, you must also complete an incident report. And in many cases, you'll need to complete two. So the first one is going to be the DDAP report, and then the second one will be a report for CCBH, or if there's another insurance or funding source that would want an incident report like this. So you can find these by going to the client drop-down menu and then selecting miscellaneous, and then you'll see the critical incident report forms there. And they're pretty self-explanatory to do, or usually your supervisor can just do them for you if they're in the loop of what was going on. So these reports should mirror the clinical documentation, but also include system level details. Who was contacted, when, and what the outcome was, if there was a case number, if there was a police officer on site. Like, we want as many details as we possibly can get. And when in doubt, just ask your supervisor which reporting pathway should be used based on the client's payer source. Even if the incident was resolved safely, it still counts as a critical incident. And as far as documenting collaboration, you want to make sure that you're also recording any communication with crisis teams, police, or EMS, any hospital staff at the receiving facility, or family members or emergency contacts. And if you're working with a substance use disorder client and couldn't disclose due to 42 CFR Part 2, but you consulted the clinical director, you want to document that too. It shows that you followed proper legal and ethical channels. And documentation really just is going to protect that client first and foremost. It's also going to protect the agency and it's going to protect you. It's how we tell the story of what happened, what we saw, and how we responded with professionalism and care. And so once the immediate crisis has passed, whether the client was hospitalized, transported, or stabilized in session, our responsibility doesn't end there. What comes next is just as important, and that's the follow up care. This is where we shift from crisis mode back into the therapeutic rhythm, ensuring that the client has the support that they need to move forward safely. So, we want to aim to meet with the client again within 48 to 72 hours after a safety event or hospitalization has happened, or sooner if possible. And this reassessment gives us a chance to reevaluate their risk level, their level of care, and review what happened and how they're feeling about it, and begin to rebuild therapeutic rapport, especially if trust was impacted by the hospitalization process. Sometimes the clients will feel relief. Other times they may feel really angry, ashamed, or disconnected. So be ready to meet them wherever they are. And any crisis, especially one involving suicidality, homicidality, or hospitalization, should trigger a review and update of their treatment plan. And so that's going to include adding or adjusting objectives related to safety, emotional regulation, insight, or crisis response. We're going to want to include referrals to higher levels of care like psychiatry, IOP, partial hospitalization, maybe long term inpatient if needed, and noting progress barriers or new risks that emerge throughout the crisis. And this update isn't just an extra step of paperwork. It really does help to realign the treatment with where the client is now, not where they were before the crisis. We also want to look at making support referrals. So, again, you do not have to do this alone. Part of the effective follow up is bringing in the right supports. So, that might include psychiatry for medication evaluation or stabilization, crisis services or mobile teams for short term outreach, peer supports for wraparound recovery assistance, or forensic or legal resources if there was a violent incident or police involvement, or maybe somebody already has involvement with JRS or probation. And so these referrals should be clearly documented and ideally discussed in session with the client to increase engagement and buy in. And finally, if this was a hard case for you, you're not alone. We expect that it'll be really difficult. So we want to make sure that we're wrapping you in care. So debrief with your supervisor, talk through what happened, how you responded, and what support you might need. Crisis work is really heavy. Even when we do everything right, it can take a toll. And sometimes it just doesn't feel right, even though we're doing everything right. JADE encourages a team approach. So lean into that support, use supervision, not just to check boxes, but to process your role in keeping people safe. And follow up is where recovery starts again. It's where we help clients feel seen, supported, and reconnected after a crisis. And that's where we want to take care of ourselves too. So before we wrap up, I just want to leave you with a few reminders, the kind that you can hold onto when things feel overwhelming or uncertain. First and foremost, you are not alone. If a crisis happens, whether it's unfolding in front of you, on a phone call, or even in a note that somebody might have written, you do not have to navigate it by yourself. Supervisors, clinical directors, and team leads are here to support you. And that's not just protocol, it's our culture. We want you to reach out. Second, safety is always going to be our top priority. No matter how complicated a situation feels or how upset a client might be in the moment, our North Star is always this: protect the safety of the client, the staff, and the broader community. This includes emotional safety, physical safety, and legal safety. Third, we want to learn to recognize the tipping point. There's a difference between therapeutic containment, where we help a client regulate and stay present, and a situation that needs to be escalated for external intervention. You don't need to be perfect at knowing where the line is, but with training, supervision, and practice, your internal radar will get sharper. And in the meantime, when in doubt, just ask. There is no shame in checking with your supervisor saying, hey, this is what I'm seeing. Does this rise to the level of a 302? We'd rather you over ask than under respond. And nobody expects you to be the legal or clinical expert in isolation. You are part of a team for a reason. So thanks for sticking with me for this training. I know it's a hard one. These are the moments that can feel really intense and even scary sometimes, but they're also where our role really matters the most. You do not have to fix everything. You just have to stay grounded, connected, and take the next right step. So let's just keep doing that together. Thanks.